So I will continue with the removal of root fillings. So what about the MTA fillings? Is it possible to remove set MTA? It's possible. I have not many, but several cases where I had to remove set MTA. How do you do that? I use ultrasonics, but big ultrasonic tape, not very thin ultrasonic tape, together with EDTA. Because if you use EDTA, you can little bit solve the set MTA. For example, this is how I remove set MTA. If you find a little space between MTA fillings and apical foramen, like in this condition, I would not do the surgery because I want to always be minimally invasive. So whenever I see a space between the root filling, and apical foramen, I use big size ultrasonic tape, maybe broken TFRKS or use ultrasonic tape, whatever you have. Then I use higher power setting, like a 5 to 7 on a scale from 1 to 10. Then I just use ultrasonics to break up the MTA between root canal walls and MTA. Then when you approach here, the apical foramen or the end of the root fillings, I use EDTA. You don't need EDTA from the beginning. But when you come close to the apical 1/3, I want to be very careful not to destroy the tooth. But in the coronal 1/3, you see a big space. So I would just use ultrasonics. But when you approach the apical 1/3, or maybe when you see the curve, I have to be careful. Then I will use ultrasonics. Sometimes I need to pre-curve the tip to go around the curve. But when I do that, I have a special technique. I only activate ultrasonics on withdrawal. I never activate ultrasonics as I get into the canal. If you do that, you will create a ledge. So if you see a curve, you pre-curve the tip, then you get into the space, then activate ultrasonics in the presence of EDTA. Then you will remove all set MTA, and you have access to the apical 1/3. This is how I use it. So for example, this is a case where I removed set MTA. This patient was referred to me because of the persistent apical periodontitis here. And you see the space between the MTA filling and the apical foramen. So that's why I keep teaching my students, do not be underfilled. Always push MTA into the periapical tissues. MTA is highly biocompatible. So nothing will happen even if you push MTA beyond the apical foramen. So look here. You see the space. This is okay, but this is not okay. This is okay because you see the void between the two fillings. So let me show you how I removed MTA here. First, you have to make a treatment plan based on the findings. So this is how I remove MTA. I'm using big size tape, usually broken tape from TFRKS. I'm just activating ultrasonics. And I keep activating ultrasonics, going down. As I approach the apical 1/3, then I need to use EDTA. I'm doing the same thing in the mesio-buccal canal and mesio-lingual canal. And this is distal canal, this is MB, and this is mesio-lingual canal. So this is EDTA because I'm approaching the apical 1/3. Then I'm activating ultrasonics like this. So EDTA is transparent, no color, but you see the color becomes white like this. Now I switch to a small size ultrasonic tape. This is TFRKS because I need to be careful not to create a ledge. So it's possible actually to remove set MTA, as you can see. Especially when you see a lesion surviving the retreatment, MTA is not completely set. So it's easy actually to remove MTA. It's not completely set. So keep irrigating the canal with EDTA. This is EDTA. Then dry the canal and take a look. Sometimes if you push it, you can reach the apical foramen. Because MTA in the apical 1/3 is usually not set if you see the lesion getting bigger. Because MTA will not set in an acid environment. If you see the apical periodontitis, the condition is usually acid. So MTA will not be set. I'm almost there. Here, I need to go deeper, but if you look at the MB, I'm almost there. So it's not difficult to remove set MTA. I'm not touching the root canal wall, I'm just touching MTA only. Okay, let me skip the middle part, because this is the same. Then I don't need higher power. I'm just pushing MTA with my ultrasonic tape, TFRKS. And this is EDTA. If you have EDTA in the canal, all you have to do is just push it in the apical 1/3. Then you can reach the apical foramen. I'm drying the canal to take a look. You see, I have removed all the MTA. That's why it's bleeding. The blood is coming from the periapical tissues because of the inflammation. Of course, look at the MB canal. You see the blood coming out because of the inflammation. So now I'm using XP finisher. I wanted to induce bleeding. Whenever I see a big lesion, I spin the XP and the finisher and spin it outside the root to induce more healing. MTA is very different from gut aperture fillings. So if you have MTA still remaining around the apical 1/3, it's still okay. But you have to remove bacteria from the apical 1 to 2 millimeter part. This is where you find bacteria whenever you see preoperative lesion. 86% of the bacteria located in the apical 1 to 2 millimeter. Another case, you see the lesion here, and this is MTA. I removed MTA again with ultrasonics. So this is gray MTA, this is EDTA. I have already removed MTA from the coronal 1/3 and middle 1/3. So I'm approaching the apical foramen and the perforation. So that's why I put EDTA in the canal. I'm using small size ultrasonic tape because I don't want to make the perforation bigger. And this is TFRKS, the small size one. Again, I fill the canal with the EDTA. And this is TFRKS, activating ultrasonics in the space. Then I'm picking and pulsing ultrasonics. I'm reaching the apical foramen. So this way, you can remove set MTA. As I told you, if you see the periapical radiolucency, usually MTA placed in the apical 1/3 are not set. So this is immediate post-op, sorry. This is pre-op, and this is immediate post-op. And this is MTA, and this is MTA placed in the main canal and perforation. This is perforation. You see the perforation, and you see the lesion associated with the perforation. Another case, you see the lesion, and you see the space between the root filling and the apical foramen. In this case, I needed to remove MTA. So let me show you this case. Basically, I do the same. So this is set MTA, but you can easily break up the set MTA with ultrasonics. I'm using the power 7. So if you keep doing this, and this is EDTA. When you approach the apical 1/3, use EDTA and use small size ultrasonic tape. You can even use small file like this. This is micro opener. The pus is coming out because I have reached the apical foramen. So as I told you, usually the MTA in the apical 1/3 is not set because of the asset environment. MTA will not set in an asset environment. So after that, what I did, let me go back. What I did was very simple. I pushed MTA into the periapical tissues. I do this on purpose because I don't want to be underfilled. So I push MTA into the periapical tissues. And this is 3 months post-op, already showing nice periapical healing. This is pre-op. This is 3 months post-op. Even in surgery, it's not difficult to remove set MTA because MTA placed in the apical 1/3 is not usually set. When you see periapical radiolucency, for example, this is MTA, but I didn't see the healing. So I did surgery, root end surgery. So let me show you how easily you can remove set MTA. Actually, it was not set. It was half set. So I completed root end surgery. Then, I dissected the root end. Then I'm going to remove set MTA. You see how easily I can remove set MTA from the apical end. I don't even use EDTA. I just use ultrasonics. That's it. This is good because you don't completely have to remove gall aperture and the gall aperture You don't completely have to remove set MTA. You can leave MTA, but when it comes to the gut aperture and ciliary, you need to completely remove gut aperture and ciliary. Sometimes when you do surgery, you find gut aperture remaining in the root canal walls together with MTA. And gut aperture can be the only reason for persistent apical periodontitis. And this is immediate post-op. I placed MTA as a retrofill. And this is 3 months post-op showing nice periapical healing. So now I want to show you how to remove biofilms. But this is very similar to gut aperture removal because gut aperture usually have biofilm formation on it. So this is the protocol. I use these instruments to remove biofilms. I use ultrasonics. I use gut aperture removal instrument. I use ultrasonic irrigation device. I use hand instrument. I use ProRoot MTA. You know, you can remove biofilms by placing MTA into the canal. I'll talk more about MTA obturation tomorrow. So I use them, irrigation devices, to remove biofilms. Endoactivator and ultra piezo flow. And these. So if you use higher concentration of sodium hypochlorite, like 6%, or at least 5.25%, you can chemically remove biofilms. You can go from here to here. If you have pulps, necrotic pulps, you can remove it with sodium hypochlorite. This is a very nice study. And they use 25 patients. And this is the protocol. They instrument the canal with GT files with a 5.25% sodium hypochlorite. And after the instrumentation, they use 70% of EDTA. Then they waited 30 minutes, replenishing the canal with sodium hypochlorite. Every 5 minutes, they replenish the canal with 5% sodium hypochlorite. But, they could make the tooth bacteria-free in less than 50% of the cases. So it's not effective when you use just sodium hypochlorite. It's not enough to remove bacteria or biofilms. So what do you have to do? You need to use irrigant reaching the apical 1/3. But normal irrigation is not enough. This is normal irrigation. So you cannot reach the apical 1/3. This is staining. But if you use endovac with a negative pressure, you don't have to be in the apical 1/3. You just use irrigation with a negative pressure. Then you can remove irrigant from the apical 1/3. You can reach the apical 1/3 with the irrigant, sodium hypochlorite. Or you can just use gut aperture cone, one size smaller than the final preparation size. And you need to use push and pull motions, maybe 100 times per minute. Then you can deliver sodium hypochlorite into the apical 1/3. But reaching the apical 1/3 with sodium hypochlorite is not enough. It's not enough. Because this study showed it's not enough to reach the apical 1/3 with sodium hypochlorite. There was no significant difference between the endovac and irrigation needle groups in antimicrobial efficacy. So it's not enough. You need more power to remove biofilms from the apical 1/3. So that's why you need to use ultrasonic activation. So this is piezo flow. When you activate ultrasonics with irrigant, sodium hypochlorite, with a small up and down motion, you can reach the apical 1/3. As you continue using a small up and down motion with orthosonics, you can reach small anatomical spaces such as an isthmus or lateral canal. As you go down, you create positive pressure. As you pull the instrument, you will create negative pressure. So that way, you can actually remove necrotic pulp tissues from small anatomical spaces, such as an isthmus and lateral canal. So let me show you how effective you can be to remove the biofilms from the root canal walls. For example, here, this is graffiti on the wall. You need higher water pressure to remove the graffitis or painting. If you just, splash water against the wall, you cannot remove the painting from the walls. You need more power. Power is generated with higher pressure. So this guy is going to use higher pressure against the wall to remove the graffitis. So he is going to use this machine. Look here. He can easily remove the painting from the wall. He's just using water, nothing else. But he's using lots of pressure. So with the pressure, you can remove the painting from the wall. So if you do the same in the root canal, you can remove the biofilms from the root canal walls. So for example, this is calcium hydroxide stained with Caris detector dye. And this is normal irrigation. If you just irrigate the canal with water, this is just water. You cannot remove calcium hydroxide apical to the tip of the syringe. I'm here, but I cannot reach the lateral canal. I cannot reach the second lateral canal. I cannot reach the apical 1/3. I'm just removing calcium hydroxide where I reach the place. Nothing was removed apical to the needle, the tip of the needle. However, if you use orthosonics, agitated, then you can have more pressure. So let me show you. I'm in the same situation. I put calcium hydroxide in the lateral canals and the main canal. I'm going to use orthosonics. I deliver water from the syringe. But my assistant is suctioning water from here. So as you can see, I can immediately remove calcium hydroxide from the lateral canal. I don't have to be in the apical 1/3. I don't have to be in the lateral canal. But as you can see, I'm removing calcium hydroxide from the lateral canals. And you see calcium hydroxide in the apical 1/3 is being removed with a small up and down motion. In the end, everything is gone. Okay, so this is how I remove biofilms from small anatomical spaces. So I developed an irrigation device with woodpecker. This is a new irrigation device, similar to piezo flow. But difference is you don't need an assistant to suction the irrigant. So this is suction here. This is suction. And this is the needle tip. So if you express sodium hypochlorite or even water with a small up and down motion, you can remove biofilms or necrotic pulp tissues from small anatomical spaces, like this. Actually, you can even remove a broken instrument with this device. Let me show you how you can remove the broken instrument. Of course, you need a preparation to remove the broken instrument. So let me skip the preparation part, because I will show you how to do it tomorrow. So this is the end of the preparation. So the broken instrument is here, beyond the curvature. This is 6002 high flex EDM. So you see lots of debris, and this is the broken instrument. So this is the new irrigation device. I'm using it in an up and down motion. So debris is coming out. Then you see the broken instrument is also coming out. Look, like this. This is super easy. You just have to prepare the canal and loosen the broken instrument, then use this device. Even if you have calcium hydroxide from the lateral canal, you see calcium hydroxide. Actually, this is the MTA. I filled MTA in the lateral canal. But if you use this device, you are removing MTA from the root canal wall. I'm reaching the root surface. Look here. Now everything is coming out. So you can do this. This is very cheap and simple. It's important to simplify complex. So if you look at the studies on piezo flow, they are all good. Significantly better elegant delivery into lateral canals with piezo flow. Significantly better isthmus debridement with piezo flow than manual irrigation. So if you look at the Hapasolo study, this is the piezo flow. And you see the staining, you see the purple staining in the apical 1/3. You don't have to be here, but you have to use small up and down motion with ultrasonics. Then you can remove staining from the apical 1/3. So debris can be removed 10 millimeters apical to the irrigation tip. So if you do this, like this, if you do that, for example, you see the lateral canal, and you see the apical periodontitis. First, you need to remove infected dentin, and you will instrument the canal with sodium hypochlorite, and you will irrigate the canal with ultrasonics. Every canal, I press sodium hypochlorite 30 minutes. I replenish the sodium hypochlorite every 5 minutes. Then this is immediate post-op. You see MTA filled in the isthmus here, as well as the main canals. And this is immediate post-op. And of course, the patient became asymptomatic. But it's not 100%. Even if you use ultrasonics for irrigation, 80% of the cases became negative. So it's not 100%, but it's much, much better than irrigation needles, like this. So what else can you do to reduce the bacteria or to reduce biofilms? You can simply enlarge the canal to size 60. If you enlarge the canal to size 60, you can eliminate 100% of the cases. You can eliminate bacteria in 100% of the cases. Because you can go from here to here. Sometimes you have no apical constrictions. Actually, you have, the tapers, upside down taper, like this. So you need to enlarge the canal to size 60. Then you can make the root canal bacteria-free in 100% of the cases. So, if it's persistent, I always do this. I instrument the canal up to 60 O2. This means I use 60 O2 high-flex EDM. Then usually I see the healing in a shorter time. But remember, you have to prepare the canal to the size smaller than, you need to, sorry, let me put it this way. You have to have the apical preparation size bigger than the irrigation size. For example, if you are using number 50 irrigation needle, your preparation must be bigger than size 50. If you use the irrigation needle that is bigger than the needle size, you will not reach the apical 1/3. So that's why apical preparation size must be bigger than irrigation needle size. In this study, they showed irrigation needle size must be smaller than the root canal preparation size. Then you can remove the biofilms. So since the minimum needle size is number 30, the final preparation size should be at least larger than size 35. So I always enlarge the apical foramen size up to size 35 because the smallest needle size is number 30. And also, if you use XP Endo Finisher, I think XP Endo Finisher is number 1 to remove the biofilms, according to this study. So XP Endo Finisher appears to be more efficient than other 3 techniques using endo activator and PIPS, which is an albumin laser, YAG laser, and also the normal irrigation system. And PIPS appears to be most effective in killing the bacteria deep into the dentinal tubules, but it doesn't matter. So you can just use XP Finisher to remove the biofilms. And also this study, again, showed, this is one of the Hapasolo studies. He found significantly more biofilms using XP Endo Finisher compared to other irrigation techniques, such as ultrasonics or manual irrigation technique. So in conclusion, I recommend you use both PiezoFlow and XP Endo Finisher, because if you use XP Endo Finisher, you can remove almost 90% of bacteria from the root canal, but you still see debris or bacteria remaining in the coronal 1/3. Whereas if you use PiezoFlow, you can have 94% of bacteria reduction, but you still see bacteria remaining in the apical 1/3. But if you use both PiezoFlow and XP Endo Finisher, you can make it almost 100% free, bacteria free. This is how I choose the techniques. So let me show you my techniques. So this is staining. I got staining in the 2 lateral canals. And this is PiezoFlow. So immediately I reach the apical foramen. But look at the root canal walls. Still you see staining on the root canal walls. But after you use XP Finisher, I'm going to use, but look here. You see the bubble coming into the lateral canal, and here is the same. I'm removing something from the lateral canals with the PiezoFlow. But you must use small up and down motion. When you go down, you will have more positive pressure. If you go up, you will have more negative pressure. So with positive and negative pressure, you can reach small anatomical spaces, such as an isthmus or lateral canal. Then I'm going to use XP Finisher scraping the root canal walls like this. After keeping doing this, in 1.5 minutes, you see all the staining completely disappeared. So this is my protocol to irrigate the canal before the obturations. Completely gone. So you can start from here to here. You see the staining in the lateral canals completely gone after I use the piezo flow. But you still see staining on the root canal walls, so they have to be removed with a XP finisher rotating at higher speed, 2,000 or 3,000 RPM. Then everything came out. So now I want to talk about the last topic, management of ledge canal. And this is something I do every day because 98% of my cases are retreatment. So I do this almost every case. So I have to tell you characteristics of ledge formation. As you know, ledge forms almost in a straight line. And ledge forms on the outer wall. The ledge never forms on the inner wall. So you can see the ledge forms almost in a straight line. And it's always on the outer wall against the curve. And the entrance to the original canal is on the opposite side of the ledge across the midline of the curve. This is very important. This is how you locate the original canal. How do you locate the original canal? I always look at the opposite side of the ledge across the midline of the curve. So for example, this is the midline of the curve. If you want to locate the original canal, always look at the opposite side of the ledge. You will find it here. So this is the ledge, and this is the midline. Always look at the opposite side of the ledge across the midline of the curve. For example, here, this is the ledge, and this is the midline. And if you look at the opposite side of the ledge across the midline, you will find the entrance to the original canal. So this way, you can easily locate the entrance to the original canal. This is how I locate the original canal. Very easy. Nothing difficult. So, prevention of the ledge formation is always more important than bypassing the ledge. So how do you prevent the ledge formation? This is also easy. If you do this all the time, you can always prevent the ledge formation. So first, you have to do pre-coronal flaring. Always start with the pre-coronal flaring. So the first instrument I always use is number 3 GG bar to create a funnel shape. Always start with the GG bar to create a funnel shape. So if you create a funnel shape, you can reduce the curvature. If you reduce the curvature, you can easily instrument the curved canal. But if you created a ledge without doing the pre-coronal flaring, it's never too late to bypass the ledge. How do you manage the ledge formation in this kind of situation? Again, start with the number 3 GG bar to create a funnel shape. You need to remove the ledge portion. So you need to open up the canal. Then you need to enlarge the entrance to the original canal. How? I always use ultrasonic tape. Okay, ultrasonic tape. It's very, what kind of ultrasonic tape? I use TFRKS, very small one. How do you get TFRKS into the original canal? First, you need to locate both the ledge and the original canal. You precurve it, and try to get into the original canal. Whenever you get into the original canal, you feel sticky on withdrawal. When you pull it from the original canal, you feel sticky. So take a radiograph whenever you feel sticky with the instrument. And if you are in the original canal, activate ultrasonics only on withdrawal. Then you can enlarge the entrance to the original canal. This is how I manage the ledge. So if you do that, you can open the entrance to the original canal. Make sure you make a funnel shape first. Then locate both the ledge and the entrance to the original canal. Actually, if you switch from the rotary instrumentation to reciprocating instrumentation, you see a decrease in instrument fracture and ledge formation. So that's why I always want to use reciprocating motion instead of rotary instrumentation whenever I see a curvature more than 30 degrees. If the curvature is less than 30 degrees, I don't care about instrumentation. I just use rotary instrumentation. But if it's more than 30 degrees, the instrument will not follow the root canal path. So that's why you need to use reciprocating motion. In addition to that, you need to use multensthetic phase nickel titanium instrument to instrument the crazy curvature or to instrument double curvature. Because this study showed multensthetic instrument like a wave and gold or high flex EDM were found to cause lower level of ledge formation than conventional nickel titanium instrument in austenitic phase. Because, multensthetic phase nickel titanium instrument has less restoring forces. If it's an austenitic instrument, it has lots of restoring forces. That's why it wants to straighten out around the curve. But when it comes to the multensthetic phase nickel titanium instrument, it doesn't have restoring forces. That's why when it is curved, it stays the same way. It doesn't go back to the original straight line. And there are three tip designs. There are only three tip designs of each instrument. One is pyramid, the second one is conical, the third one is biconical. The instrument with the pyramid tip is the most aggressive. And the instrument with the biconical tip is the least aggressive. So it's better to use the instrument with a biconical tip. You can prevent ledge formation with these instruments. So let me show you a case. So this is TF, and you see the curvature more than 30 degrees. I'm using rotary instrumentation with a TF. TF has conical tip, not biconical tip. TF has a conical tip. So if you continue rotating the TF, you can make a ledge on the outer wall. You see the ledge getting bigger and bigger. I cannot go beyond this point. As you can see, ledge is getting bigger and bigger as I continue rotating the instrument clockwise. So this is what happened if you continue using rotary instrumentation around the curve. But if you simply use reciprocating motion, that is 380 degrees clockwise, 50 degrees counterclockwise at 150 RPM, it will be completely different. I'm going to use the same TF. I'm going to use the same plastic block with a curvature more than 30 degrees. 5 minutes, okay. So let me show you what will happen if you use reciprocating motion. You see, this is the same plastic block, and this is the same TF. However, I'm using reciprocating motion, 380 degrees clockwise, 50 degrees counterclockwise at 150 RPM. You see the difference. How you instrument the canal affect the outcome. Look, I have already passed the point where I created the ledge in the previous plastic block. But I completely passed the ledge point. I'm already here. I didn't create a ledge around here. I'm going to irrigate canal, then continue doing the reciprocating motion. 380 degrees clockwise, 50 degrees counterclockwise at 150 RPM with the same instrument. Look here, I'm almost to the apex. I'm reaching the apex without creating a ledge. Okay, I have reached the apex. I didn't create a ledge. Look at the curvature, more than 30 degrees. And there's almost no transportation. So, if you want to prevent ledge formation, use the reciprocating motion. It's safer. What about the instrument with a biconical tip? What will happen? TF has conical tip. What about the instrument with a biconical tip? So this is ProTaper Next, which has biconical tip. I'm simply using rotary instrumentation with the ProTaper Next. I'm rotating the instrument around the curve. I'm not creating a ledge because of the biconical tip. I'm already here, but look, I separated the instrument. So if you continue rotating the instrument with a biconical tip, you will end up fracturing the instrument. Okay? But if you use reciprocating motion, it will be completely different. I'm using the same instrument, but look, this is reciprocating motion. 380 degrees clockwise, 50 degrees counterclockwise. Every time, whenever you see debris, irrigate the canal. Look, I'm efficiently reaching the apex. I'm already here. I didn't fracture the instrument. And I'm reaching the apex. Look, I'm touching the apex. There's no transportation. There's no ledge and no instrument fracture. I have reached the apex. So reciprocating motion can prevent you from fracturing the instrument and creating a ledge. So this is very good. So that's why I use these instruments with a biconical tip and also multi-synthetic phase instrument. Or I developed new instrument from a company called H-Endo. This is a new instrument coming very soon from the company called H-Endo. And this is the instrument, this will be the fourth instrument. The fourth instrument. You know, as I told you, there are 3 tip designs. And this will be fourth tip design, completely different from the conventional tip design. And I use TF, I use the instrument with the biconical tip, I use multi-synthetic phase nickel-titanium instrument. These are the instruments that I use to bypass the ledge.